I'm going to talk about an overview of adult ALL, and we're going to have a bit of a debate afterwards about exactly what we've just answered, which is what is the role of allogeneic stem cell transplantation in CR1 versus ongoing chemotherapy. A couple of things before I start. This is a beautiful bridge in downtown Melbourne, which is where I'm from. And for those of you who are interested, the Haematology Association of Australia and New Zealand are having a big meeting in Melbourne this year in late October. Beautiful time to come to Melbourne, springtime, so plenty of time to register if you want to come. Unfortunately, abstracts have closed, but come along anyway. So what are the problems in adult ALL? Well, there's a few things here, and you can pretty much read them for yourself. As we know, ALL is not just one disease. Not only are there different cells of origin, T and B in particular, but there's wide differences between different age groups. The majority of the patients who achieve CR relapse, unfortunately, and the most effective regimens for ALL are also the most toxic. Here's an analysis of 100 or so patients that I did going back about 8 or 10 years ago, unpublished, but really just a bit of an internal audit from our unit, comparing 50 patients with low-intensity therapy pre-1995 compared to those treated with an MRC UK ALL type protocol or a BFM type protocol, so-called high intensity, identifying that really the outcomes were much the same. So what could we conclude from this? Well, around about a third of patients, adult patients with ALL, are relatively easy to cure. You can give them fairly weak chemotherapy. As long as you give them some chemotherapy, consolidate their response and give them some maintenance therapy, about a third will remain in remission. And if you intensify the chemotherapy in a blinded fashion, you really don't improve the outcome much, and we'll talk about the reasons why this may be the case. So how do we cure more patients with ALL? Well, our options are to proceed to allogeneic stem cell transplantation, as we've just questioned ourselves about, or intensify the chemotherapy without allogeneic transplantation, as is increasingly the case with the so-called pediatric-inspired chemotherapy regimens. But importantly, when we try and apply either of these approaches in the adult population, we have to be mindful of this as well, that to cure more patients, we have to achieve, yes, more disease eradication, but not kill more patients in the meantime. So we have to have less non-relapse mortality. And that's a very important contributor to why adult patients do less well, for reasons that we'll see. So what happens to those patients if we do induce them into remission? What happens if they relapse? And this is a very important slide taken from the large ECOG UK ALL database, which are those patients who were treated on that regimen. If they relapsed, what was their outcome? Their outcome was terrible. So in fact, the opportunities to salvage patients with ALL have improved a little since this data was published, but overall the best time to cure somebody with ALL is the first time you treat them, rather than waiting and see what happens and salvage them when they relapse. Now, Professor Champlin talked about the relative lack of improvement in elderly AML over the decades of therapy in AML, and similar data is available for adult patients with acute lymphoblastic leukemia. This is published a few years ago now, but I think it's useful that the largest improvement in outcome has been in the younger patients when we compare outcomes for those treated in the 80s compared to those treated in the 2000s, and that there is, yes, improved outcomes in the young adults, but as we get into the older adults, the improvement over the time periods has lessened, indicating that there are significant biological and therapeutic differences, tolerability differences in these patients when we try and deliver them more intensive chemotherapy. Very important summary taken from Nicola Gobudget and Holtz's work. Nicola's actually coming to join us at the HAA meeting in Melbourne, so if you're interested in that, come down and hear her speak. And they make a couple of useful contributions here with respect to their overview, in that we should see an improvement in the cure rate of relapsed ALL if we apply stem cell transplantation. But as I've already said, we should try and avoid our patients relapsing in the first place, and that in relapsed ALL, perhaps fatalism isn't justified, but for reasons that I'll go into, identifying those patients who would benefit from stem cell transplantation early is a key manoeuvre. Here's another review also by Dieter Holzer that, as I've already said, ALL is curable in a third of adult patients, and of course there are important immunological, clinical and cytogenetic characteristics which I'll go into in a second. And then if we apply these stratifications and modify the therapy accordingly, we should be able to get more than half of these patients cured, possibly by transplanting them. So what should our best expectations be in newly diagnosed adult ALL? So when a patient with ALL walks through the door, what should our expectations of their outcome be? Well, as I've already said, this is probably still the most important data set published in Blood a few years ago from the UK ALL study in conjunction with the ECOG group. And we see here that in standard risk, Philadelphia negative adult ALL, where patients who had a donor were transplanted, their expectation of outcome 5 years out was greater than 60%. Those that had no donor, they are still achieving 53% overall survival. And the key difference here being, in this red box, that those patients who underwent allogeneic stem cell transplantation had very significant transplant-related mortality rates, which really eroded much of the benefit of transplantation. If we, and I've just drawn this line in, this is my own artistic impression, that if we take that steep drop-off there in, between about 6 months and 9 months, which is when most of these patients had transplants, if we erase that and just duplicate this survival curve and lift it up to there, then perhaps by reducing transplant-related mortality, we might well be able to achieve 75% cure rates in standard risk adult ALL with transplantation. This really highlights the point that I've just made, that whilst the benefit in overall survival in that large study was primarily shown for patients with standard risk disease, and the relapse rate, or the degree of control over the leukemia, was equivalent whether you had standard risk disease or high risk disease, but the benefit was eroded in those patients with high risk disease because of excessive transplant-related mortality. So that's one of the challenges that we face in adult ALL. Similar improvements were seen in TALL, and that's the only slide I'm going to show you on that. So with respect to an overview of the treatment of ALL in 2012, really not much has particularly changed. Combination chemotherapy, utilising multi-agent regimens, but particularly with the more widespread addition of allosparaginase, and including re-intensification with Ara-C, cyclophosphamide, and high-dose methotrexate, with other multi-agent chemotherapy regimens, and very importantly, maintenance therapy being applicable in the majority of subtypes. With respect to treatment intensification, what about paediatric regimens? Well, we know what paediatric-inspired regimens can actually deliver. They provide an increased drug intensity. That really importantly can only be appropriately deliver their benefits if there's strict adherence to schedule. And this is one of the key differences between applying these protocols to children versus applying them to adolescents or adults. And there appears that if you utilise these regimens, that there perhaps is a reduced role for hematopoietic stem cell transplantation in standard risk patients. But a couple of the unknowns is how applicable are they to older patients, and what is the long-term outcome in adults? So we'll come back to that later. So what about risk stratification? Much of this will be obvious to you already, but if we think about younger age, lower white cell count, particular phenotypes of ALL, absent CNS involvement, various molecular or cytogenetic abnormalities, and the ability to achieve an early remission are all favourable, and the contrary is true as well. Older patients, higher white cell count, etc., associated with a less favourable outcome. And these various risk stratifications have been shown in a number of large studies to result in significant differences in disease-free survival, where none of these risk factors being present are associated with an improved outcome, whereas higher numbers of these are associated with a poorer outcome. One of the key things, and this question was asked, has been asked until recently, is what about MRD, minimal residual disease? And it was unclear whether this was an additive or a replacement for these clinical risk stratifications. And I think we have some data now that perhaps helps clarify that. Really, this is a very dense slide, but really just to show you that by applying these cytogenetic, molecular, clinical, and white cell count risk stratifications, that the application of stem cell transplantation in most, but not all studies, has been associated with an improved outcome when patients have been transplanted in first CR. So risk stratification has been applied to a number of prospective studies, and here is some data from, or some designs from the UK ALL14 study, showing that previous publications have shown the importance with respect to white cell count, that age was a had a significant prognostic impact and poor outcome, both with respect to the ALL and tolerance of hematopoietic stem cell transplantation, resulting in excessive transplant-related mortality. Cytogenetics, of course, is well established as a risk factor, and then MRD being increasingly identified as a risk factor for failure of therapy. This is a publication again from that same data set, and really not going into the details of this, but really at all phases of therapy, those patients who were persistently MRD positive had a poorer outcome than those who had MRD negativity, and I'll show you some updated data about that in a second. Here was a couple of other brief reports that had shown the impact of MRD persistence as being a poor outcome in patients with ALL, Philadelphia negative ALL, and in particular this GMAL 0703 trial has just recently been published, in fact yesterday. A lot of authors, all excellent work, technically a fabulous paper, and from a large data set of over 500 patients looking at the impact of persistent minimal residual disease positivity, and importantly for today's discussion, the impact of stem cell transplantation. Here is the kinetics of becoming MRD negative on that protocol, and you can see that at various days they did scheduled MRD assessments. The actual analysis that I'm going to show you was done with respect to the MRD result on day 71, but you can see that with ongoing therapy, the average proportion of patients achieving MRD molecular responses increased through time, being more rapidly achieved and more likely to be achieved in standard risk disease than in high risk disease. And really, this is really the action slide, these next few slides here, which shows that if they take standard risk and high risk patients and analyse them together, including those patients who had transplantation in CR1, you can see this stratification with high statistical power between those with persistent MRD here and those who had become molecularly negative at day 71. If they reanalyse the same data but now look at those patients who did not receive a stem cell transplant in CR1, you can see that those patients had a very poor outcome indeed, with less than 10% being cured with standard chemotherapy. And this was the survival curve. So this was the continuous complete remission, and these were the survival curves really showing the same pattern. This table here really just wanted to highlight a few things which was really which will be helpful with respect to our debate, which is those patients who had no stem cell transplant. You can look down here at the percentage who had ongoing complete remission, disease-free survival, really in the 10% or so mark, range, with those that had actually achieved a stem cell transplant having substantially improved ongoing remissions, ongoing survival, and ongoing disease control with high statistical probability. What was the chances of you having ongoing complete remission if you had standard risk disease, ALL, and did not receive a transplant? Pretty poor if you were persistently molecularly positive with persistent minimal residual disease, and if you were considered to be high risk on clinical characteristics and MRD positive, your outcome was extremely poor indeed if you did not receive a transplant. So really we have this approach here, which is, should we have a risk-adapted approach to transplantation or an unrestricted transplant approach, where the unrestricted transplant approach is transplant all adults who have an HLA-matched donor, or just try and identify those patients who could be safely avoid transplantation, who achieve MRD negativity and therefore no transplant up front. And that's really going to be the question for us shortly. I think I might, because I'm out of time, but I might restrict my final comments just to a few remaining slides. This is one of my favourite slides about allogeneic transplantation, and that we really are attempting to be angels and deliver the best and most caring care to our patients, but not rushing in unnecessarily to excessively toxic therapies. So our primary decision really in adult ALL, in my view, is not transplant and CR versus wait and see what happens in transplant in beyond CR1, wait for the patient to relapse and then transplant them later, but to identify those patients where no planned transplant is necessary, and by converse, identify those patients where transplantation in CR1 is the appropriate thing to do. I think I'll stop there. I did have some more slides considering the type of conditioning regimen, whether we should have reduced intensity conditioning regimens as part of our armamentarium. All of those, I think, are relatively subtle points, and this is really the key question here, is how best to identify patients who should be transplanted in CR1. So with that, I'll thank you, and perhaps we can have our debaters come to the stage. Thanks very much.